Good morning again, everyone. So my task is to follow Jean-Louis Vincent after he gave us a very nice introduction about the importance also of clinical examination and going back to basics to understand really if there is a problem with the perfusion of our patients. And I like to follow on that because very often when we talk about volume responsiveness or hemodynamic monitoring and stuff, we fixate a lot on the response to our therapeutic interventions. But actually, the very fair question should always be, is there a problem with perfusion? And is my perfusion adequate or not? And is the manipulation of hemodynamics useful to improve the perfusion? Now, if we answer that question positively, then of course, thinking about fluids is important in shock. And we all have this in our mind. We're probably tired of seeing this curve, but it is basically the cornerstone of the reasons why we decide if I give a fluid bolus, a fluid challenge to my patient, I really want to see if that patient is on the ascending part of the Frank-Starling curve. Because in that way, if he's increasing the stroke volume, the cardiac output, then I'm gaining something in terms of the delivery of oxygen to the tissues. And on the other hand, giving fluids when there is no response really doesn't make any sense to me. We are probably just overloading the patient with an unnecessary amount of fluids. We don't get any benefits here, and before we start to pay significant prices for what we are doing. We often think about the circulation in terms of cardiac output and arterial blood pressure, and of course it's very important. But if we go back to the basics, we also have to remember that there is not just the arterial side of the circulation, there is also the venous side of the circulation. And I think we forget sometimes to think about fluids in a way that Guyton taught us many, many years ago now, and basically saying that the main determinant of venous return and therefore cardiac output is the oxygen demand, is the metabolic demand of the tissues in the periphery. And if we describe the physiology in that way, in the physiology of the venous return, then we need to start to look at the circulation in a slightly different way. If I imagine that all my vessels, arterial, venous, and all the vessels in which I have blood in my system, I can imagine them as an elastic band, then I can think that part of the blood will be in this elastic band and will not generate any pressure. That's what Guyton described as the unstressed volume. Now, part of the blood then, due to the properties of the vessels and to the amount of blood that is inside, or to the volemia of the patient, generates some pressure on the system, on the walls, and that's what Guyton defined as the stress volume. So it is the stress volume that generates then this pressure that Guyton described as the mean systemic filling pressure. And why is that important? Because, and I apologize for the simplicity of this cartoon here, but if I understand this concept, so the concept of volume that is distributed in unstressed and stressed volume, and I know that I have a pressure here, which I described as the mean systemic filling pressure, then in order to have a venous return from the peripheral circulation to my heart, and if I look at this as my right atrial pressure and therefore as my CVP, I do understand that a good heart works to maintain the CVP as low as possible. And this is a concept that I don't know why, but somehow in the years we sort of forgot about it. And this is very important. If I want to have flow, I need to have a gradient. So for any degree of mean systemic filling pressure here, the CVP will have to be lower, not higher. Indeed, if I measure the CVP in this room now, hopefully, if all of us are in relatively good health, the CVP will be very low, probably around 0. It doesn't mean that we are all hypovolemic or that we need now to receive massive amount of fluids. Things, of course, change when I have a sick patient in my unit. When I have a sick patient in my unit and I decide to give fluids because I want to improve the perfusion, what I'm trying to do really is trying to increase the stress volume here. Because for whatever reason, because of bleeding, because of redistribution of the volume and etc., I want to restore the pressure here. My goal is this. The knock-on effect, of course, is that by increasing the pressure here, sometimes I will see an increase also in the CVP, but that's not my goal. In a way, it's the side effect of giving fluids. And therefore, it's not a surprise that we started to see lots of negative studies that show that using CVP as a guide to fluid management, really it's a nonsense. So I can have patients that have a high value of CVP and they may still be responding to fluids. Of course, if I'm able to increase the gradient of the venous return by giving fluids, it will still work even for a high CVP. And on the other hand, lower values of CVPs, I can still have patients that will not respond to fluids with an increase in cardiac output. We demonstrated this concept of the gradient of the venous return also in a clinical study in which we showed that exactly this is what happened. If I give a fluid challenge, patients that increase their cardiac output are the ones that are able to see an increase in the gradient of the venous return. Therefore, if the CVP increases a bit, it means that the mean systemic filling pressure should have increased more. And on the other hand, patients that do not respond with an increase in cardiac output, but if the mean systemic filling pressure has increased, it means that either the CVP is increased for the same amount or the resistance in the system has changed. So, if I looked at the CVP, and I like to look at the CVP, and indeed every time I have a patient in my unit that have a central line, I want the CVP to be transduced, because it's telling me a lot about how the system is reacting to the interventions that we're doing. But it should not be our goal for the volemic management of our patients. So for instance, if I measure the stroke volume or the cardiac output here, and I plot a stroke volume preload curve, and for a patient with a failing heart or with a not performing heart, I also plot the CVP and the preload curve. And then I plot maybe a good performing heart, and again the corresponding CVP preload curve. Let's imagine I take this patient, I've been told they were in shock, they received some fluids in the emergency department, and now I'm starting from these 2 points. So one patient is already on the plateau part of the French-Sterling curve, the other patient is on the ascending part of the French-Sterling curve, but I do not know this until I measure what happens, or until maybe I will show you later, we can stress the system to predict what may happen. And again, I can have CVP values here. As you see, they can be very close. And remember that the CVP value is affected by many factors: the intrathoracic pressure, the degree of transmission of the intrathoracic pressure, to the vascular pressure, and so on. So the way to look at this, really, it's a dynamic way. So even when we say that the CVP is not a dynamic marker, it is true if I look at the absolute value of the CVP, but if I look at what happened to the CVP when I give a fluid challenge, when I do an intervention, and I see at the same time what happened to the cardiac output, it's a dynamic way of looking at things. So I give a fluid bolus, the poor performing heart. If I look with my echocardiography or with my cardiac output, I will see very little increase in stroke volume or no increase at all. Now, if I don't see any increase in stroke volume and cardiac output when I give fluids, there are 2 explanations. Either one, I've not given enough fluids to the system, or I've given fluids, but the system is not able to cope anymore with that amount of fluids, is not able to push forward the fluids that I'm receiving. In that case, the CVP is a very valuable safety alarm. It's telling me, look, the cardiac output is not increasing, the CVP change is going up, this is a patient that is not responding well to fluids. Let's think about another strategy. On the other hand, if I see an increase in cardiac output, and maybe no little to no changes in the CVP, this is a patient that is tolerating fluids. It does not mean that this patient requires fluids. I should have asked that question before, but this is a patient in which if I decide to give fluids, maybe I'm still getting more benefits than costs. But if I look at this, first of all, for extremes, I can see that the CVP will rise a lot with no changes in cardiac output. And on the other hand, the good changes in stroke volume may have very little to no changes in CVP. But the gray area is massive. And in between these 2 extremes, it's very difficult to understand to what happened if I don't measure at the same time flow, if I don't understand to what happened to my heart and to the cardiac output of my heart. So, at the same time, though, this is also telling us that very low values of CVP, at least they are telling us that that heart is pumping everything forward. So the take-home message is absolute values of CVP should not be used to guide our management, but at least if I see that the CVP value is very, very low during a shock state, probably starting to give some fluids is not necessarily a bad idea because that system is not stretched to the limit yet. Now, these things are interesting because if you remember many years ago we had goals of CVPs of 8 to 12 even in the surviving sepsis campaign. This has been taken away now. We used to have these goals, and I still in my practice when I go rounds and I see practice in the hospital, and I will show you the results of the Fenice study later. Still, we like to use a lot the CVP, and we like to use a lot absolute values of the CVP. And I would argue that this could even be dangerous. This is a sub-study of the VAST study, which was a study that looked at vasopressing in the context of shock. And what the authors found was that if you look at patients that received fluid therapy in this study, and you separate them by the amount of fluids and the level of CVP that they reached after some days of fluid management, as you see, the highest your CVP, not the lowest your CVP, the highest was your mortality. And this to me is basically telling the same story that the physiology of the Guyton was saying. So, very importantly, we need to start to think in a different way to this. And I'm not going to spend too much time with this. This is evidence that is out there for many years. But the bottom line is overloading our patients with an unnecessary amount of fluids is not really what we should be doing. We have observational evidence that shows that a very positive fluid balance is associated with worse outcomes. Of course, partially this can be explained by the fact that very sick patients may require more fluids than others, but at the same time, there is certainly a signal that we may add a little bit of iatrogenic arm by giving fluids without really measuring what happened. And this is coming up in a consistent way in more and more series. This is a large database analyzed by the group of Marek again. They plotted predicted versus actual mortality in these patients, and they found that again when the fluids were reaching very high volumes in what was given into the resuscitation, it looked like there was a discrepancy between observed and predicted mortality, and in the sense that giving too much fluid probably was associated with a higher than predicted mortality. Despite that, and this is not a study of 15 years ago, this was published only 3 years ago with Daniel and Jean-Louis, among many of the co-authors of this study, we actually found out that the CVP is still the most used variable at the bedside. And we still are using the CVP in terms of absolute value. I think this could be potentially dangerous. And it's dangerous also, I think, the way we looked at the responses to fluids. Of course, if I have a patient in my emergency department or in my intensive care unit that comes with hypotension, I'm giving fluids, and the blood pressure goes up, I don't need a very fancy monitor to tell me that that patient is responsive to fluids. But we don't treat just those patients. And we have a lot of patients in which, unfortunately, the blood pressure response after a while doesn't tell us anything. Still, we use blood pressure as our main variable to look at what happened to the system when we give fluids. And we've demonstrated that, unfortunately, when you give fluids to patients that are very sick, that have been on catecholamines for a while, and you try to optimize them a bit more, if you don't measure flow, you may be completely blind to what happened to those patients that may still be responsive to fluids. So, for instance, if I give fluids to a patient, I don't see any response in blood pressure, but that patient that increased their cardiac output, if I don't measure the cardiac output, I could be completely blind to this. It's a bit like fluids are vasodilating the microcirculation, therefore the blood pressure stays the same, which is not necessarily a bad thing if I see that the cardiac output has increased. But again, if I don't measure it, I will not know. And we have lots of tools that we can use to measure this now. Echocardiography, I agree with what was said before. I think it should become point-of-care testing. There's no point of requesting an echocardiography examination from a cardiologist that maybe comes 2 hours later. When I want to know about that patient, I need to know that in this moment, in 5 minutes after I've given some fluids, the situation may have changed. Better to have basic skills, but to use it in all of these patients when they need. And at the same time, we can couple this assessment also with continuous hemodynamic monitoring. The continuous hemodynamic monitoring is also giving us the opportunity to look at the circulation in a slightly different way, and even to think about fluid responsiveness in a different way, because we can look at interactions between the heart and the lungs, for instance, to predict even before we give fluids which patient will respond or not to fluids. I will talk into more details into another talk in this conference about the physiology of heart-lung interaction and how the venous return may change considering this. But to keep it very simple, and Jean-Louis Teboul group as being one of the pioneers in this world of prediction of fluid responsiveness. If I overimpose an airway pressure on the ventilator to an arterial pressure waveform, well, there will be changes that are related to the changes in the intrathoracic pressure. These changes are not just in terms of preload, they will also affect the afterload of our ventricles. But when we look at fluid responsiveness, we are focusing mainly on the preload response of this. And there is a cyclical variation in my cardiac output, in my stroke volume, and this cyclical variation is then transmitted also to the pulse pressure. And there are a lot of devices now that can analyze this variation for us. And if I respect some conditions, and therefore that the patient needs to be completely adapted to the ventilator, there shouldn't be no arrhythmias at all, and in theory the tidal volume, but I will show you something later, should be more than 7 to 8 milliliters per kilogram. This is being proven to be a pretty reliable variable to predict fluid responsiveness. In my practice, I find it easier to apply in the operating room than in our patients in the intensive care, where often I like to put them in pressure support early. I like to use low tidal volumes, and sometimes, unfortunately, we also get some arrhythmias. But if the conditions are maintained, then we can use this to predict fluid responsiveness. Remember, I just mentioned very briefly a few seconds ago, the changes of the ventilation are not just on preload. And if the changes in afterload are more important than the changes in preload, then the conditions to apply this may not be actually maintained. So therefore, if I have a patient in acute cor pulmonale, the changes that I see on the arterial pressure waveform are more related to the changes in the afterload rather than the changes on the preload. I will have to be very careful in that patient. If I've not done an echocardiography examination to understand this, I think that the patient is fluid responsive, but then I give a fluid challenge and I don't see an increase in cardiac output. That should be a warning signal that maybe something else is happening. This was demonstrated also into this experimental study by the group of Takala, in which the animals that had a very high degree of right ventricular failure, they were not able to have a good reliability of these indices to predict fluid responsiveness. An interesting concept that has been developed by the group of Sheila Naina-Miatra and Jean-Louis Teboul has also been the one of seeing whether we can change slightly the tidal volumes when we use protective lung strategies to actually test the system for a very short period of time. And in this study, and I understand that you're doing more studies now to prove this also in patients with different conditions, what was proven was that if I increase just for a few minutes this, even in patients in which normally the tidal volume wouldn't be enough to predict fluid responsiveness, then this slight increase for a few minutes is able to predict which patient will respond and not. Even in the ones that I cannot apply this, I can still use heart-lung interactions, and so therefore if I have a patient that is adapted to the ventilator, decreasing the degree of pressure on the ventilator will release the stress volume into the system, so I will have an increase in venous return if the patient is a fluid responder. So this is what, again, the group of Jean-Louis Teboul has developed, and it is called the end expiratory occlusion test. If I cannot apply any of this, and therefore I cannot think about using heart-lung interactions to predict which patient will respond to fluids or not, again, the group of Jean-Louis has developed another test, which is the passively grazing test, in which if I have a patient connected to a cardiac output monitor, I move from the semi-recumbent position to a legs up position, then the slight increase in cardiac output that I could see is able to predict which patient will increase to cardiac output or not. I think it's a very valuable test. I have to say in my practice it works well. Again, if the patient is relatively well sedated and adapted to the ventilator, if the patient is a bit awake and maybe moving from the semi-recumbent to a legs up position sometimes can create some changes that are just related to the fact that the patient is reacting to this maneuver. But again, if the conditions are maintained, it's definitely something that we can use to avoid giving fluids in those patients that may not be responding to fluids. Apart from all this chapter of dynamic fluid variables that we can use to predict how a patient will respond to fluid or not, there are other devices out there that they can look at volumetric variables that can guide my management. In the sense, the transpulmonary thermodilution, there are some devices out there. They can give me some idea about intrathoracic blood volume or about extravascular lung water. So the distribution of the water in the system, it's also very important. It's probably more important in those patients in which the amount of fluids they've given for a few days before of the pathology like ARDS may impact significantly on the distribution of fluids in the lungs of these patients. And there are some studies, observational for the moment, that show that a high extravascular lung water, for instance, is associated with a higher mortality. This is a study that I'm going to show you just to tell you that just because we have the availability of monitoring now, doesn't necessarily mean that using these variables is going to help us to do a good choice. To do that, there will never be a monitor that can tell us what to do with any patient. And indeed, this is a study that was published a few years ago. They randomized patients in shock and with ARDS to receive management either with the PICCO catheter, so volumetric monitoring, or with the CVP. And the targets that they put were targets that they thought were quite physiological, so an intrathoracic blood volume at 150, keep the extravascular lung water around 10, and if it goes up, start some furosemide or start some renal replacement therapy. Well, that's not the way I work in my practice. For me, shock is a very dynamic state. What I do now may be completely different from what I do in 3 hours and in 4 hours, and what I do tomorrow probably is going to have a completely different focus from the first hours in which I'm just trying to save the patient from dying. And tomorrow maybe I will start to think I need to start to get rid of some of the fluids that I used yesterday. So it's not a surprise for me that using an approach like this in which one size fits all didn't show any difference in outcome at all. And worse, probably was even giving some harm to a subgroup of patients. To me, it does not mean that this device does not work. I think the information that we can get from these devices is still very useful, but how we use it is a completely different ballgame. So to conclude, what did we recommend in a consensus that we published together with all the speakers that you find in this session this morning? Well, of course, assessing volume status and volume responsiveness is just the best practice. I don't think we need any study to prove that. I think it is just normal practice, should be as doing a proper clinical examination in our patients. There is a lot of evidence that shows that using a dynamic approach to predict which patient will respond to fluids or not is the right way of doing it. And if we decide to give fluids, let's do it in a controlled way so that we are giving fluids, but we're also testing the system. So we don't just open the drip, we give a fluid challenge and we see there what happened. Just to conclude, I've also would like to show you something else. We like to think about short-term strategies, but a short-term strategy doesn't necessarily mean that the long-term goal may be preserved. And I find this follow-up study from the FACT study very interesting. If you remember, the FACT study was a study in which a conservative fluid management approach was shown to be beneficial in terms of ventilator-free days in patients with ARDS. And I do agree that in the majority of patients, probably that's the right way of looking at things. If I take 100 patients with ARDS, I like them to stay more on the dry side than on the wet side. But patients are different. And maybe there were some patients, even in that study, that could have benefited from a bit more perfusion despite the lungs still being worse. And what they found in this follow-up study was that the degree of cognitive dysfunction was higher in the patients that were managed with a conservative strategy. Don't get me wrong, I don't think that we should change overall our approach to patients with ARDS. But again, these big studies, they do not tell us how we should maybe individualize things in patients in which maybe the perfusion was not as good as in others. So, can one size fit all? No, I don't think so. I think that's the beauty of our specialty, is that yes, we should have a very similar approach for our patients, for all our patients, but having a very similar approach does not mean that we give the same therapy to all of them. And I think that's one of the nice things about the job that we do. So my take-home message is always assess volume status and fluid responsiveness. If possible, use the predictor of fluid responsiveness every time. And the goal, let's not forget, is always the perfusion. Thank you.